Good morning. I'd like to thank the organizers for inviting me to this meeting. It's really exciting to be in a room with so many people who have such an appreciation for the respiratory muscles, and really looking forward to the next couple of days. So I've been tasked with briefly surveying a range of methods for assessing respiratory muscle function, most of which I think you're probably already fairly familiar with. So hopefully we can get through this quickly and easily. So why should we measure respiratory muscle function? Well, in the ICU, our major concern is with getting our ventilated patients off the ventilator. And as you know, respiratory muscle function is a key determinant of the success of liberating patients from the ventilator. So if we have patients who are having difficulty weaning, we may want to assess respiratory muscle function to understand whether weakness of the diaphragm or other muscles is contributing to the difficulties. But there's emerging data that respiratory muscle function is possibly an important determinant of your longer-term clinical outcome. The data I'm showing here is from a recent paper by Adler and colleagues, Laurent Bouchard's group in Geneva, where they measured Sniff nasal inspiratory pressure, which we'll talk about in a minute, at 7 days after the ICU stay. And what they showed was that patients with inspiratory muscle weakness at that time point were much more likely to be readmitted to the hospital in the ICU. So the respiratory muscles are probably important well after you leave the intensive care unit. When assessing respiratory muscle function, there's a number of important variables that we really have to take into account. First of all, the level of muscle activation. And one of the key challenges to assessing the diaphragm and other muscles is achieving maximal volitional muscle activation. There's of course the intrinsic contractile properties of the muscle. The length-tension relationship of muscle needs to be considered in the context of the diaphragm that's really affected by your end expiratory lung volume. And the diaphragm is a unique muscle because it doesn't generate, it doesn't function primarily by generating tension along its surface. It functions by generating pressure through its piston-like action. So we are not only considering length-tension relationship, but also its mechanical advantage, which is governed by the law of Laplace. And then finally, the force-velocity relationship of muscle, which is basically a derivative of the length-tension relationship. The faster the diaphragm contracts, the less pressure it generates for a given level of activation. So all of these factors need to be considered when we're assessing function of these muscles. So probably the most widespread and commonly employed technique is simply the maximal inspiratory pressure. And probably most of us here have made these measurements. And essentially you attach a one-way valve to the tip of the endotracheal tube and coach the patient to make maximal inspiratory efforts against the closed airway, a Muller maneuver. And this has been well validated, it has good reproducibility. And Marini and Truitt showed in the early 90s that this can be measured with good reliability even in non-cooperative ventilated patients. What they did was they measured airway occlusion pressure. Then they didn't tell the patients what they were doing. They basically told them it was going to be tough to breathe. Put the one-way valve on the tip of the endotracheal tube for 20 seconds. The patients progressively made bigger and bigger efforts. They took the valve off, added some dead space to stimulate drive, and then coached the patients to do a second MIP. And what they showed was that if your initial respiratory drive measured by the airway occlusion pressure was high enough, there was no significant difference between the naive or uncoached MIP versus the coached MIP. So what this suggests is that in patients who aren't interactive, who are delirious or non-cooperative, by adding some dead space to achieve adequate respiratory drive, you can simply put the one-way valve on the end of the endotracheal tube and get a reasonably valid measurement of maximal inspiratory pressure. A second technique that I already mentioned was the Sniff nasal inspiratory pressure. And this technique has been reported in outpatients. Basically a small wax plug is fitted to the tip of a catheter. It's placed in one of the nasal passages, and the patient is instructed to take short, sharp sniff efforts. And there's a rapid learning curve to this, and what has been shown is that after about 10 sniffs, a patient achieves maximal inspiratory effort and diaphragm activation. What's nice about the Sniff maneuver is it's a highly coordinated, almost subconscious reflex type of maneuver. So the patient doesn't have to think about what they're doing, or there's not a lot of training involved. And these data here from Neva and all, again, the early 90s, show that you can achieve levels of activation of the diaphragm that are as great as or even greater than a standard molar maneuver. And in fact, the Sniff nasal inspiratory pressure is often higher than the maximal inspiratory pressure. So this is a very nice technique, highly reproducible in outpatients. It's interestingly never been attempted in mechanically ventilated patients, or at least reportedly attempted to my knowledge. But this is an area of interest because, again, if we can get our ventilated patients to sniff through the endotracheal tube, then maybe this would be a way of getting a reproducible measure of respiratory muscle function in ventilated patients. Now, the gold standard in the field at this time is magnetic twitch stimulation, and some of the real experts in the field with the use of this technique are in the room. This technique basically involves applying magnetic stimulus to the phrenic nerve. It's not nearly as barbaric as it looks. And basically, the beauty of this technique is that it's non-volitional. The patient's relaxed, and the magnets deliver a standardized stimulus to the phrenic nerve, which in turn delivers stimulus to the diaphragm. And although I've only used this in the research lab setting in outpatients, it really gives you a very consistent measure of respiratory muscle function. Nevertheless, I think there's a number of challenges associated with this technique. First of all, these instruments are quite expensive. They're not widely available. I think they require a fair amount of technical expertise to employ, certainly initially. And these measurements are probably quite vulnerable to variation in end expiratory lung volume. And there's a number of other issues that need to be considered, like twitch potentiation, where if a patient coughs or takes a deep breath before a twitch, that's going to significantly affect the pressure that's generated. So some groups have been quite successful in using this technique in the research setting, but it's not clear to me that this will ever be a technique that we'll be able to use widely in the clinical setting. Maybe some of you disagree. I'd be interested to hear from you after. One important point is that the twitch pressure measured at the airway and the twitch pressure of the diaphragm are not the same. There's a small bias, and the limits of agreement are quite wide. So unfortunately, we can't use the airway pressure measured during a twitch as a specific assessment of the diaphragm. They are, however, well correlated, and so probably vary together over time. So changes in twitch airway pressure probably reflect, or could reflect, changes in twitch transdiaphragmatic pressure. A technique that Dr. Leo Hunks has described is the use of neuromechanical efficiency. And the idea with measuring neuromechanical efficiency is that you're measuring the mechanical output of the diaphragm or other respiratory muscles as a function of the electrical input. And in this figure here, you've got patients before and after receiving either placebo or levosimendan. And you've got the EMG signal, which Jennifer already very nicely outlined for us. This is the raw EMG tracing. The black is before the administration of the study drug, and the blue is after the administration of study drug. And what you can see is that while in the patient who receives placebo, the pressure generation and degree of EMG activity are similar before and after the administration of placebo. Whereas with levosimendan, you achieve the same pressure generation, basically because that's a function of the loading task, but the EMG activation required to achieve that pressure is much lower. And so when you quantify that ratio by the pressure divided by the root mean square of this EMG, you basically have a way of quantifying the neuromechanical efficiency or coupling of the muscles. This has been shown to be a predictor of outcome of spontaneous breathing trial. Here you've got neuromechanical efficiency quantified in patients who subsequently pass an SBT and patients who fail an SBT. And what you can see is that neuromechanical efficiency is consistently higher over the course of the SBT in the patients who pass. One of the challenges with this technique is there's no sort of normal value, although you can see that patients who failed consistently tended to be below a value of 1. Nevertheless, there's probably no individual normal value. So this technique is really more useful for looking at changes within patients over time rather than comparing between patients. Again, neuromechanical efficiency is vulnerable to some of the variables we discussed at the beginning, changes in length-tension relationship and mechanical advantage. This is an interesting experiment reported by Frank Olagi's group, where they applied a progressive threshold loading protocol and basically showed that I actually was one of the subjects in this experiment. So they drove the subjects all the way to respiratory muscle fatigue. And I can tell you it was painful. And what they showed was that twitch pressures of the diaphragm were actually lower at the end of the experiment than at the beginning. So they really were inducing muscle dysfunction and fatigue. But nevertheless, what you can see is that over the course of this fatiguing protocol, neuromechanical efficiency actually improves. And that they thought this was likely related to the significant increase in abdominal muscle activation. And so you can see that even in a patient whose muscle is likely fatiguing, your neuromechanical efficiency might actually improve because of the significant benefit of recruiting the abdominal muscles. So as a measure of muscle function, this is vulnerable to changes in abdominal muscle activation. Another important consideration is the force-velocity relationship. So this is data from a very interesting paper recently published by Ewan Goligher, where they looked at the coupling of EDI to inspiratory effort during ventilation with NAVA. And what they reported was that for higher levels of, we're reporting here the integral of EDI, or electrical time product, I sometimes call it, it wasn't clearly correlated with pressure time product. And of course, if these were exactly coupled, you would expect there to be a linear relationship. So they spent some time in their discussion trying to think about why it is that during NAVA, the EDI and inspiratory effort level weren't as well coupled as they expected. My own theory about this is that because they didn't measure neuromechanical efficiency using a random airway occlusion, that there is a great deal of variability in the relationship between EDI and PDI, because there's probably a great deal of variability in the inspiratory flow during all of these measurements. And back in the 70s, a very nice paper from the Meekins Christie lab showed that the relationship between EDI and PDI is critically dependent on the inspiratory flow rate. And this again is because of the force-velocity relationship of muscle. The faster a muscle contracts, the less force it generates. We collected some data from an ongoing study in our center, where we apply random airway occlusions to measure neuromechanical efficiency. And in our data set, the integral of EDI is actually strongly correlated linearly with the integral of PDI. So when measuring neuromechanical efficiency, you really have to take into account the force-velocity relationship of the muscle. Some brief words on some ultrasound techniques to measure diaphragm function. So this is increasingly employed throughout ICUs around the world. And one technique is basically to measure the excursion of the diaphragm. So a phased array transducer, similar to what's used for cardiac echo, is placed just below the costal margin and allows you to visualize the dome of the diaphragm. The ultrasound is placed into M mode, and you can actually measure the movement of the dome of the diaphragm up and down while the patient's making an inspiratory effort. And the magnitude of that movement can be a measure of respiratory muscle function. Normal values have been published for different types of maneuvers like quiet breathing, sniffing, deep breathing, and these measurements all have excellent reproducibility. So, for example, a normal minimum value of diaphragm excursion during quiet breathing would be to see at least 1 centimeter of excursion. Interestingly, Kim and colleagues measured diaphragm excursion during unsupported quiet breathing at day 3 to 4 of mechanical ventilation, and showed that patients who had an excursion greater than 1 centimeter had much shorter subsequent time on the ventilator, shorter duration of weaning, shorter ICU and hospital lengths of stay, compared to patients who had diaphragm excursion less than 1 centimeter. measured at that quite early time point. So again, these data suggest A, that this is probably a valid way of assessing diaphragm function, and B, that again, diaphragm function is probably an important determinant, or potentially an important determinant of clinical outcome. Another technique about which we've done a great deal of work is the use of diaphragm thickening during mechanical ventilation. So if the ultrasound probe, the linear array transducer, similar to what we use for line placement, is placed on the side of the chest in the zone of apposition, you can easily visualize the diaphragm in cross-section between these two bright echogenic lines, which are the fold of the parietal pleura and the peritoneum. And this space in between, relatively hypoechoic, represents the diaphragm. And when a patient takes a breath, you can see as the diaphragm shortens, it thickens, and so you can visualize this thickening again in M mode, and the normal thickening value is about anywhere between 30 to 40%. During mechanical ventilation, this thickening fraction is proportional to the patient's inspiratory effort and can be measured with at least moderate reproducibility. Some recent data suggests that the thickening fraction of the diaphragm during a maximal inspiratory effort is actually correlated with your inspiratory or your maximal inspiratory pressure. And in patients, when measuring diaphragm thickening fraction during a spontaneous breathing trial, the patients who fail have a much lower value of thickening fraction than the patients who succeed. So all these data suggest that, again, the thickening fraction is a valid way of assessing the diaphragm function. So which should we be using? Excursion, thickening, is there really a difference? This data was just published in Critical Care, and what you can see is that what these authors did was they varied the level of pressure support, and at lower levels of pressure support versus higher levels, there was really no difference in the degree of diaphragm excursion visualized, whereas diaphragm thickening fraction was clearly very different. Now what these data really show is that excursion is a function of insufflation of the chest, so you can't really use the excursion to assess respiratory muscle activity during while the patient's on ventilatory support. But I think it also suggests that the excursion that's measured is vulnerable to the mechanical environment. And one of the interesting hypotheses that we're working on right now is that excursion is probably more affected by your lung and chest wall mechanics than diaphragm thickening. So we wonder if diaphragm thickening might be the superior ultrasound technique, but that really remains to be shown. So just to quickly summarize, we've talked about maximal inspiratory pressure, sniff pressure, twitch pressure, neuromechanical efficiency, and some ultrasound techniques. Ongoing questions are whether a sniff maneuver might be a useful technique in ventilated patients, and sorting out what the best ultrasound approach for assessing diaphragm function is during mechanical ventilation. Thank you very much.